Hello, I'm Tom Blankenship with Citi, and I'm excited to be joined today by two strong and dynamic physician leaders, Dr. Sharif and Dr. Silverstein. We're going to be discussing on today's panel, physician executives and regional growth. Let's begin with a brief intro from each of you. We'll start with Dr. Silverstein.
Great, thanks, Tom. Appreciate it. Really glad to be part of this, and thanks, Dr. Sharif, for joining me in this presentation. So Kent Silverstein, I'm at ChristianaCare, which is an independent academic medical center in and around Wilmington, Delaware. I'm trained as an anesthesiologist, and I serve as the chief physician executive here. I've been in the role for about 6 years, but I've been part of this ChristianaCare community for almost 30 years, coming here to practice anesthesia, as I did for the first about 24 years of my tenure in the community.
Great. I'm Ghazala Sharif. I'm an ER doc by training with a fellowship in pediatric emergency medicine. Went on to take over the ER at Rady Children's Hospital here in town. Went back and got an MBA because I thought I needed a little more training on the business side. And ultimately, I've worked my way up at Scripps, first starting in physician communications, then as a patient experience officer. And in January, took over as interim chief medical officer along with another partner of mine who took on the outpatient side right before COVID hit. So I call it my COVID CMO hazing. It's been an interesting challenge, but now officially the chief medical officer on the acute care side for Scripps. So I'm actually very excited to be here with you, Ken and Tom. It'll be a good conversation.
Great. No, looking forward to it. Thank you both again for joining. So we'll go ahead and begin. And first question is going to go to you, Ghazala. So our first question is, how has COVID impacted your organization? And in particular, how has your perspective on health system capabilities changed?
Yeah, that's really the question of the day, isn't it? I will tell you that COVID has given us much more clarity and much more direction that we have learned as an organization, that we can pivot quickly, we can make very quick decisions. You know, before COVID hit, it would take a long time. We'd go to this committee and then that committee and then consensus back to the other committee. I see Ken smiling, back around again, and then they'd have to discuss it all over again. And we have learned that we can definitely focus and move things along much faster. And everybody's really excited about that across the organization. So we started what I call sprint teams. And what that means is that we pick a specific topic and we drill down into all the opportunities that we have around that topic. And so we started this before COVID hit with our Leapfrog sprint team, and they've been doing amazing work. We started a physician sprint team around the definitions of surgical site infections, because that was driving our physicians nuts. And we've already got some advocacy work going, but now we're drilling into things beyond COVID, readmissions, surgical site infections, catheter-associated urinary tract infections, all with a specific team in mind, and great work's already underway. So it's changed my thinking around organizational capacity, because I think when we focus and we all focus in the same direction, things get done and they get done quickly, and people seem more engaged now than they ever were before. You think it would be the opposite, that people get so tired of COVID only that we don't do anything else, but we've been doing COVID plus this new direction. So I'm actually pretty excited to see what the next year will bring, given this new strategy that we're seeing. Ken, I'd be curious to see, you know, if you're having that same impact at your organization as well.
Yeah, no, it's so interesting to see how, I mean, every health system was faced with that challenge and how they stood up to face it. And, you know, we overnight became a COVID diagnosis and treatment center, and a broad array of clinical services were curtailed. And that required that incident command structure that you're talking about, the ability to be incredibly nimble. And we learned that we could, in fact, be nimble and have effective execution, rapid decision making, just as you said. You know, so again, with the singularity of focus we had on COVID, that we were able to do that. And you know, the interesting thing will be to see if you can continue to pull that forward. I will tell you that we entered the pandemic. We had a really clear vision of where we thought the future of healthcare was, where we were headed in the future of healthcare. We entered the pandemic really well grounded in our mission of service to the community. Really well grounded in our core values. At ChristianaCare, we have two core values. They're love and excellence. We really understand those. We had clarity about our strategic initiatives, you know, in population health, and, you know, the aspirational pursuit of the quadruple aim. And those things never wavered all the way through the COVID pandemic. Those guideposts of mission, vision, values, strategy, that allowed us to really focus on the work that had to be done and lean on those things in sort of meaningful ways. And so important developments were accelerated. You know, we knew that we were heading in the direction of virtual care enablement. We shortened that timeline by months, if not years. Right now, all of our employed practices are virtually enabled, and we have virtual services offered across the entire system. So I think that's for me, it's shown us this window of the future of healthcare, and we're sort of doubling down on healthcare transformation. To your point, how do we continue to move that work forward? One of the things we stood up a virtual COVID practice to take care of patients who were positive or suspected of being positive that didn't require hospitalization. We used a care management platform to do that, asynchronous, synchronous communication. We learned firsthand that care doesn't have to revolve around a visit with a doctor. So that kind of learning is going to be really important to pull forward. Just last thing I want to say about the impact of COVID is that it really highlighted the health disparities that we know exist and just intensified the urgency with which we have to sort of attack those disparities and seek to eliminate them.
Oh, that was great. Yeah, no, the accelerating trends is one thing that we definitely saw across the spectrum in terms of COVID, and that was a great answer for both of you. Yeah. Moving over to our next question, Ken, how has COVID impacted your views of geographic presence or footprint, as well as reshaped your perspectives on partnerships in acute care along the continuum of care?
Sure, Tom. It really cemented the need, our community presence and the duality of the relationship between the system and the community and the system. Our mission is we serve our neighbors as expert caring partners in their health. And people needed us, and we were there for them. We provided care, we provided testing, we provided answers, we provided perhaps a modicum of stability in a really uncertain time. Turns out we needed the community as well. And the outpouring of support was overwhelming in its impact and generosity. Personal protective equipment was donated, meals were delivered, flowers sent, signs of encouragement and appreciation were absolutely literally everywhere. So that locality of being was really cemented. At the same time, virtual care, which was a big play here, virtual care is boundaryless. A good video connection renders geography essentially moot, and that really has changed the possibilities of our roadmap for the future. So we're really thinking about that. A comment on partnerships, there was a world in our health system and probably in a lot of health systems where we were pretty insular about partnerships, like all capabilities had to be developed internally. And we were already moving in a direction where we recognized that through partnership, we might be able to enhance existing capabilities or bring in those capabilities that we didn't even have. I think the enormity of COVID and the need to rally around and bring all hands on deck really accelerated that thinking.
To tag on to what Ken said about the community support, I will tell you that the outpouring of love that we felt in our community is priceless. I mentioned Starbucks earlier, but just the free coffee for the Starbucks meant a lot to our staff. We felt like people really appreciated what they were doing and all the donations that Ken mentioned. The partnership part was different for us because we're a border community, so we started seeing people come across our Tijuana border, and then we had an outbreak in Imperial County, and they were literally asking for as much help as they could get. And so in addition to San Diego's outbreak, we were dealing with basically border communities coming in to seek care. And so we had to put together a plan pretty quickly about how to support those patients. And I will tell you, those patients were critically ill, getting transferred in for ECMO, heart-lung bypass, because they did not have that capability where they were at. And then the panic that caused when we started seeing numbers in our southern regions. That led to immense partnership across the region. Really, our chief execs started meeting with each other, and then I facilitated a chief medical officer regional meeting. We were meeting every week. Now we've gone to every 2 weeks. The amount of collaboration that has brought up has been amazing, to the point now where people refer things to our CMO group, but they don't know what to do. Testing criteria. Oh, why don't we give it to the CMO group? That to me has been the silver lining in all of the COVID work, and I know that we'll continue that collaboration even beyond COVID. We bring policies, we share each other's memos, just so that because we want to try and stay lockstep. Because you can imagine there's a no visitor policy in place at one hospital, the other one's allowing visitors. We hear pretty quickly what's going on. Oh, they've got the PPE, we don't have the PPE, and we just decided as a region of health execs that we didn't want to be put in that position, especially with all the labor unions and then rest that was already present within our staff and physicians. So the silver lining has absolutely been the partnership. We compete on a different level, but when push comes to shove, we come together, and this has been the highlight of that.
Ghazal, if I could just comment, we certainly saw that as well. I'm curious, one of the things that was a real challenge was requests coming in for things like PPE and even staffing. You mentioned some really vulnerable populations, and that opportunity I'm sure you faced. It's so hard to know about the apportionment of resources so that you can keep your own caregivers safe. Did you wrestle with that at all, or?
Yes, and so my ER doc training, you prepare for the worst, right? So what we did is we were tracking all of you. Everybody was tracking resources very closely, and so what I did was we put in a reserve of 30% above our peak volume. So and it varied. At one point, we had 130 COVID patients across our system. So at every moment, right now, I can tell you, if I had an outbreak right now, we in reserve have 30% of our required PPEs ready to go. And so no one was allowed to tap into that. We all were told to stop elective surgeries. I know you have that as elective. Really, nothing's even elective. All these people waited forever. The only thing elective is cosmetic surgery, but we closed everything down, right? And so with that 30%, when we started reopening, we weren't allowed to tap into that 30%. So you could do as many procedures, but keeping that in reserve for my rainy day. And that actually has served us very well. There are a couple of organizations in our area that actually had to reach out for supplies because they weren't managing as closely. And I'm happy to report that we haven't had that happen. Not that it can't going forward, but that was our piggy bank. So it's a really good question. How about you? What did you do?
There was a nursing home, long-term care facility we actually sent staff and PPE to, because it was better to keep the patients there and sort of shelter in place. But that, it's challenging because you can't just do that to every single facility across the region.
No, that's great. And again, I know you guys, you can never hear it enough, but we're all greatly appreciate us non-healthcare workers, everything that you do, from the executives to the front line. I mean, I know my family, we sent stuff across. We're not in either of your markets, but we did send to the healthcare workers and everything like that. We all greatly appreciate it, and thank you. Well, back to you, Ghazala. So no rest. So next up, we have our next question is, so over the years, how has your view of the competitive landscape evolved as you look out at markets? So particularly as it comes to defining regions and markets, and how has technology and non-traditional competitors impacted your views?
Yeah, and COVID has kind of brought to light some of the things that Ken was talking about earlier. Regionalization has always made sense to me. I came from University of Michigan and, the Mayo model. But I think we need to do more of that. The costs are getting higher and higher. The government reimbursement is getting lower and lower. And so the idea of every single hospital doing all the same things is really just not practical anymore. And frankly, as a patient, I would rather go to the top center, right? So we have started some of that work already. We have a Previs Cardiovascular Center. We have another hospital that's our comprehensive stroke center. We have Green Hospital that does a lot of our orthopedic work. So some of that's already been started, but I do think as we move forward, especially with the digital era and the amount of traction that we've had really this year, we went from literally 0 telehealth visits to within 2 weeks, Ken, you'll laugh at 3,000 video visits in 2 weeks. We thought we were going to get there in a year and a half. And frankly, our patient experience scores were higher when people weren't talking to them, but when they were able to schedule their own appointment. It was fascinating to see the pivot. That means that's what the patients have been asking for. So I think with telehealth, some of the things we're trying to do is expand our stroke guidelines and neurosciences, right? We have a shortage in the South. And so with telehealth, we can have that command center approach that we've all talked about for a long time, right? You can have a virtual ICU. One of our hospitals was actually giving advice over to Mexico for their ICU docs, just because we couldn't physically go back and forth over the border, right? And so UCSD started that. We were giving consults as well that we never would have thought about before. So I think it's a huge opportunity for us to expand outside our markets. To your question, Tom, about how do we not just market share and compete with each other locally, I think there's a lot more that can be done across the system. We have MD Anderson now. They're partnering with us for cancer care. That is something that absolutely that model could be expanded across country, right? Because you have the best of the best. You can do tumor boards electronically. And so I'm actually very excited about what the next phase will bring, because it helps us help patients beyond our immediate catchment area. That was a lot in a little bit of time, but that's
that was great. No, thanks, Ghazala. Ken, what are your thoughts?
The great points. The virtual has certainly been a game changer, but I love the introduction of the boundary of a country actually plays a very different role, a unique barrier for you there. That's really, really interesting. For me, in thinking about competition, the legacy view of competition absolutely has been sort of local, regional. Quality was our competitive advantage. The competitors were mostly other health systems, so competitive advances were pretty predictable. You could anticipate, and sort of, it was a sweet little world, right? Local competition actually remains relevant. We have a commitment to the communities we serve. We believe we want to protect them. We want to offer the very best to them, and we believe we do. Regional legacy competitors are still at play. They're potentially knocking at our borders. So I think there's still an element of understanding that competition and being able to play in that space. There's also a new view of competition, and I believe as I see it, it involves integration across the healthcare supply chain. And people are looking for that right recipe. What's the right combination? Is it payer and provider? Is it a provider and a tech platform? Is it retail and payer? And as has been the case and will continue to be the case, that integration results in the introduction of new players in the competitive landscape. And it's a totally different ballgame. And it's really going to be incumbent upon us to sort of be able to modulate, adapt. The flexibility we talked about is going to stand us in good stead as we think about, not really clear where these competitors will be coming from. What is that right mix across the healthcare supply chain? I think that's a different way that I've been thinking about competition for sure.
I can add on to that. The competition is going to come from all these concierge programs, and what we're seeing even with our COVID patients, as we realize they're getting long-term complications now, right? It's not a single system. It's not just your lungs that it's affected. It's your heart. It's your neurologic system. It's derm, and so they're not going to want to go from site to site to site to see somebody. So we're actually thinking about putting in a specific convalescent COVID clinic, right, where you can get all of that care in one time, whether it's virtual or all together versus me having to schedule 4 different appointments. That's that concierge approach that we're trying to take across the system, with this concept of navigators for every patient, because even if you just want to make a simple appointment, sometimes it takes a few steps. Sometimes, we get calls, I'm sure you do, Ken, all the time, can you get me an appointment? Well, I do that, but I want everybody to have a Ken or a Ghazala. And so we've got to become a little more patient. I know you get it all the time. It's true, and I can do it. I call somebody to get an appointment the same day, but we want that for everybody. And so that's the competition we are going to get faced with as more and more clinics go to that model. We're going to have to catch up a little bit sooner. And so we're trying to get ahead of that curve as much as we can, not just for the complex patients, but for the everyday patient as well, who just might need a little help.
Yeah, that's great. In terms of the customer experience, I know both of you are leaders in quality, so that makes a ton of sense. And the concierge service, again, is addressing the customers and what they're looking for. So we'll move to our next question, Ken. And so this is this one's pretty long, so here we go. So describe your framework and outlook on regional growth and how you evaluate its potential impact to your organization's clinical programs and services. What organizational capabilities, for instance, clinical research training, are enhanced with this growth, and what opportunities are created through these partnerships for growth? Conversely, putting your physician executive hat on, what do you view as the greatest challenges for physicians and healthcare leaders with this growth?
Yeah, that is a long one, and maybe we chunk it up a little bit here, Tom. So Ghazala has a chance to weigh in. I can talk about the framework, perhaps, and Ghazala, if you want to respond to that or have thoughts, I can pause there. But any conversation about growth has to start with the question of why grow. And growth for growth's sake for me is just not a winning strategy. So at ChristianaCare, our growth strategy is linked to our drive to value-based care and to our conception of population health. We have a working definition of population health, and it's assuming risk and responsibility for the health, well-being, and total cost of care of a population. And so in a risk-based contract, in a value-based model, covering more lives is important, right? It allows us to efficiently distribute costs. We can normalize health risk across broader numbers of people. So it makes sense to grow as we seek out risk-based arrangements and value-based models. It may be the statement of the obvious, but financial viability, sustainability, it's crucial. We have to be able to continue to invest in all the things that we need to do to take care of our community. And so, the key ingredients in financial sustainability, revenue diversification, and geographic expansion. Those we've heard that time and again, and that's part of. So when we think about growth, when we think we want to be a national expert in delivering population health and being financially sustainable, we have to grow in order to do that. So it's absolutely part of our plan. That framework, that rationale, commitment to growth allows discernment as we start to look at growth opportunities. We can now say, does this one make sense? Our guiding principles align with desired outcomes. And so, for instance, okay, here's an opportunity to grow lives outside of our primary service area. Here's a, pursuing payment for value. Here is partnering in a new business opportunity with the potential for new revenue stream. Those growth things make sense relative to our rationale. So that's how we sort of frame it out. We have certainly first gate criteria, if you will. Does it advance the strategic plan? Does it align with our values? And there's deal breakers. So makes sense. Does this carry undue financial risk? Is it incompatible with our brand promise? Does it create legal issues for us? So, at the final analysis, the growth opportunity needs to align with our mission. Our mission is simple, but it's profound. We take care of people. And so we have a great rubric for thinking through growth. We have a rationale for it. And again, at the end of the day, does it help us take better care of people? So I can stop there. I'm happy to go into what I see as potential opportunities and challenges, but I can take a breath there as well.
Let's turn it over to Ghazala. Let you catch your breath.
No, Ken, that was very well said. You're right, because growth just for growth, I love what you said, growth just to grow doesn't make any sense. And so, I have seen a lot of that where, competitor puts up an urgent care and everybody says, oh, we got to put another urgent care because they have one in North County. Now we need one without really thinking through the financial aspect of it. It's really more just they have one, I want, the Me Too approach. And I'm happy to say that Scripps, we really don't follow that pattern. It really doesn't make sense. Do we really need another one of those? We had this thing several years ago where Scripps partnered on our Proton Center. Well, other people wanted a Proton Center, but you didn't really need two in San Diego. That doesn't serve the community to have people competing for something where everybody could partner together. So I'm a big believer, yes, of growth, but what can we do to partner together as well, right? And so the MD Anderson is a great example. I'm sure there's other partnerships that we can do with other healthcare organizations, even in our area and outside, for the best care. If you think about it, one of your questions, Tom, was about regionalization. What we found through COVID was that when we shut down a lot of the primary care clinics as well, right? Because we were told to close down anything that wasn't essential, and we kept a few open. Well, patients were not happy. For primary care, they want to go close to home. On the other hand, if it's a specialty service, so I want to go to my cardiac center, I'm willing to drive, miles. Some of our people are driving up towards LA, to get their cancer care. And so it depends what you're trying to go and what you're trying to regionalize strategy-wise. So I think convenience for really tailoring about what the patient wants, right? So if it's primary care, they want to be close to home, so it makes sense to expand that catchment area if there's patients that you haven't captured yet. But where all expenses, which is on the inpatient side, I think we've got to be very careful about staying true to that regionalization and specialty, not just because of the cost, because if you do 5 procedures in one hospital because they want it there, and you're doing 100 a day in another hospital, where would you as a patient want to go where the expertise is? And that we kind of lead into the next topic, Ken, is the challenges, because we get that would make sense from the patient, but you can think about where the pushback is going to come from that is the physicians, because they want to practice where they want to practice, and trying to convince them that economies of scale, it's better for the patient. The argument has always come back, and well, I'll train my staff and I'll do what I need to do to get adherence better for our patients. But I challenge that. And so if you were the patient, where would you want to go? And so I think that's, Ken, you can chime in here, but to me, that needs to be the bigger challenge. It's easier to make institutes of specialty care. That's on the easier side of things. It's how do you get the staff to believe that is the case? Ken?
Yeah, that's a great call. I want to go back to what you said about growing through partnership. That's a real consideration, and growth, expansion, partnership. This allowed that you're talking about the opportunities. It allows you to certainly find efficiencies. You talk about centralizing resources and stuff. You can harvest synergies. If you take two entities that have actually complementary strengths, you can actually find the multiplier effect where the whole is greater than the sum of the parts. And enhancing capabilities. We have a joint venture with Go Health in the urgent care space. They brought capabilities that we just did not have and would have been costly and take a long time for us to potentially develop. We grabbed onto those capabilities through partnership. So your call on partnership is really good, and I think it's one of the clear opportunities associated with growth. In the clinical sort of realm, research and training, you mentioned the tumor board concept, the opportunity to expand communities of practice, the ability to recruit and retain top candidates, to really expand that talent pool and have your, deep domain experts at the table when you're doing care standardization, creating clinical protocols, care pathways. Like, you're better when you grow, and when if you have, 8 rheumatologists are probably better than 4 at the end in the final calculus. Accrual in clinical trials. I think another thing, a really important call out in terms of the growth, is the ability to celebrate diversity in the workforce, and that's something that we really look at. So absolutely see those opportunities. The other thing that we do look at in terms of developing our own portfolio on 2 fronts. One is to be able to generate new revenue streams. So looking at the development of unique capabilities internally for the purpose of developing new business lines or new revenue streams, but also to ensure that we can bring value as a partner. Because as you go forward and think about partnership, you want to be sure that you have an offering as well that makes you attractive. We have a gene editing institute. We're doing sort of cutting edge research in CRISPR. It's great stuff. It's really, really an interesting conversation to have, and something that can then be, in partnership, can actually spread care that way. You alluded to some of the challenges. I would only go on to say that while we talked about the boundarylessness of virtual care, local connectivity is important. And I think as you grow in consolidation, if you're now a multi-state system, maintaining that local presence and the connectivity to an individual market is more challenging. I think that, really understanding what's happening in a local market may be hard. I think you have to worry about bandwidth, individual and organizational bandwidth, at least due diligence, integration activities. You can outstrip the supply of your resources that are dedicated to those activities, and that can be a problem. That can be a real limiter in terms of growth. And then you mentioned the clinicians. Especially if you're integrating private practice physicians into your employ, and now they were used to being a 2-person practice, and now they all of a sudden have to deal with these massive HR policies, and how do I get my vacation requests and CME reimbursement, and it feels impersonal, and it may in fact impact their ability to really deliver care locally. So there are clearly some concerns and challenges associated with consolidation.
Yeah, but on the other hand, you mentioned clinical trials that by partnering, we can do so much better for so many patients, right? We may not have the clinical trial availability at one site, but maybe there's some place up in LA that we could, and just having that open communication actually serves our patients much, much better. So I think that's another opportunity, Tom, when you say regionalization, we can expand beyond our catchment areas for these clinical trials. I mean, COVID above everything else has shown how much we need that speed of change. And so I think that's another opportunity that we can learn. Back to your first question about COVID, what did we learn? We need that. We need to do more of that collaboration.
Yeah, I would imagine your MD Anderson partnership has been really helpful in terms of that.
Absolutely.
Yeah, that's great. That's fantastic.
Right. Well, back to you, Ghazala. So, given both of your organizations and their focus on patient experience and quality, how does your organization incorporate the community and patient stakeholders as you evaluate growth opportunities? I know we've hit on this. We definitely touch on this because this is key for both of you, and you can hear it in your voice and see when you speak about it. But if you could elaborate a little bit more on this.
I think that there's a standard ways, right? The Press Ganey surveys, all the surveys that we do, and we do follow-up phone calls on the discharge. So we do a 48-hour phone call for patients discharged from the hospital, because we don't want to wait till the survey comes, so we figure out what is it that we should have done differently. So that's a very focused effort to make sure our patients get what they need when they go home. If they don't understand their instructions, that's a dissatisfier, right? They don't feel like they got what they needed. They're likely to bounce back on the readmission side. That being said, we also have focus groups. I'm sure, Ken, you have the same thing if there's a particular area of interest. We have an online survey. We have about 8,000 patients who've signed up to be on our through MyScripts portal. They're a consumer group, and so if we have a specific question that you can do demographically, we can send it out to all 8,000 of them that want to participate. So it's multi-pronged across the way. But I think our change now, when you mentioned quality and patient experience, and for years until just January, when I decided to restructure things, patient experience is in one bucket, and the quality department is at the other end of the hall doing their thing, and there's absolutely no integration. If you think about it, patients expect quality. They don't expect to come to the hospital and get a surgical site infection, right? They expect that they're going to come and be safe. So how do we marry the two of those together so that they're not separate departments? And that's really where the fun of COVID has come in, right? Because we've had to do not only the clinical side and making sure we don't get hospital-acquired conditions and things like that, but how do we enhance that patient experience? So this is an exciting time for both of us. And we have two CMOs here because we're actually mingling the two sides together. And I do think we're going to get much better traction, not only on the quality side, but on the patient experience side, because they overlap so much. If you don't understand your instructions, you're going to go home and you're going to have a readmission. That's one of the three government programs, right? There's hospital readmission reduction, hospital acquired condition reduction program, and then there's a value-based purchasing program. And they all interlock with each other. So somehow we put it in two separate buckets, but the government hasn't, right? And so the closer we can get to bringing those together, the better. And so that's really the sprint teamwork that I mentioned earlier. It's not just about reducing readmissions. It's about the patient experience on their journey. How do we get to them before they decide to come back to the ER? People don't like coming to the ER if they don't have to. Can we find them an alternative route? So you say, I'm feeling a little more short of breath. Most of the time, they don't have to come to the ER. Can I get you a televisit tomorrow, right? Or maybe they just want to talk to somebody, or they ate a bag of chips, a week after congestive heart failure. They're feeling better, eat a bag of chips. Well, they don't need to come to the ER for that. But once you pounce in the ER, you're almost guaranteed I'm going to readmit you, being an ER doc, because I don't want you to go home and, I don't know. So what resources do we give you in the ER for those patients that don't need to go home, televisit? And so how do we track those patients across the course of their entire journey, making sure they get to their post-discharge appointments? It always struck me as we tell patients to follow up in 48 hours with their cardiologist, and then we never know if they did or not. Should we be making those appointments for them before they leave the hospital? But we're putting that all on the person who doesn't feel good. And I can promise you, if I'm not feeling good, I'm not going to pick up the phone, wait on hold, and then be told that the doctor doesn't have an appointment in 48 hours to see me anyway. And so how do we provide that seamless care that interacts absolutely with patient experience, because they're not getting bounced around, right? And the quality will go up because they're not getting bounced back into the hospital or having all these questions that we never answered in the first place. So that was a little bit of a long-winded answer. You can see this is where my passion is, because I think that this has been the missing link all these years. Quality patient experience when it's like joined together at the hip.
Yeah, Gonzalo, good for you on that. You're describing the virtual cycle it actually starts with caregiver experience. If your caregivers are having a good experience, the patients will have a good experience. They'll get quality care, and costs will be reined in. And so, that virtuous cycle is so key. And, for you to bring those together in such a deliberate way, congratulations. That's awesome work. At ChristianaCare, we have a deep commitment to health equity and to our community, of course. We have a chief health equity officer, and she oversees our community engagement strategy and the programmatic development and those projects. And so anchors us to this concept that community partners are absolutely essential to our ability to deliver on our mission. And we're constantly reminded by Bettina about this. And so we make investments in our community. We have a community investment fund. We last year invested $2 million in 32 different community organizations that are engaged in health improvement initiatives. There's a purpose-built community here in Wilmington, the city of Wilmington, called Reach Riverside, and we've invested heavily in that in terms of developing. It's an underserved area, part of the city, and creating access points and such. So this allows us, these investments, we think of them as investments, and they allow us to impact the health of those we serve. At the same time, we can stay attuned to the needs of that part of the community, which is so important. So, of course, we have a strategy and planning team that goes out and surveys locally and regionally, as all health systems do. We pull that information in around demographics and business developments to stay up to speed with what's happening in the region. And we do have a patient and family advisor program. It's quite robust. We have a patient and family advisor council. Gonzalo, I like what you said about reaching them electronically, because I don't know that we've really thought about how we connect up with these folks in the virtual sort of COVID way, because we actually have patient and family advisors. We have a process, they get vetted, and then we sit them on different committees across the organization, and so we're getting real-time feedback from a patient or a family member around strategy or project implementation, literally across the system. But obviously without in-person meetings, that's a little bit harder to maintain, and it's something that we really need to be considering.
It's been very helpful. We designed our whole billing department. We put in a centralized billing office. And instead of us designing what the bill should look like, because we all think we know what they want, we actually sent it to this advisory group and got close to 2,000 answers within the first week about what they wanted. And so we designed the bill around them. You mentioned community outreach, and I think that's really important. So part of this program, this discharge follow-up appointment, is for those underprivileged folks. you can't tell them to go to the local community clinic. We know that doesn't work. And so we've established 2 different clinics. One is it's a pilot, and we're hoping to extend this. It's a hospitalist who felt passionate about this. She actually goes into the patients' homes, our high-risk patients, that 1% that actually charge, 80% of the bills. And she actually does home visits for those patients. It's remarkable that she's built a team that's willing to do that. Despite all of that, there's a few that keep wanting to call the ER and call 911 anyway. And some of those we figured out were really for the emotional side of things. They were feeling lonely. So it wasn't the medical part of things, that they wanted some company, and they would call 911 so they would be seen by somebody. It's fascinating what we're finding out. So it's not just about the care that they're getting. It's what other sources in the community do we need to provide them with? Is it a visitor, home visitation? Are there volunteer people? There's so many people that want to do volunteer work to add to the clinical side of things. And then at one of our other hospitals, we have an acute care clinic to get these high-risk patients in when they can't be seen by their physicians. So that's part of the work that's underway to bring those 2 sites together.
So I'll offer you a tip on the loneliness thing. We give out iPads, and we have people on our care management team, not necessarily nurses, that call people and talk to them.
Just really, that's great. That's the thing. Then they won't call 911. We finally said, "Why are you doing this?" "Well, I wanted to see you guys." Here's my picture. Hang it in your living room. But it was an aha moment for us as well, because it's not, we think we're treating the medical side in it. It's so much more, as you know. So that's a good, so you give it an iPad to go home with. So that's how okay. That's a good thought. This is great. I love exchanging ideas.
No, this is great. I mean, this is as much for you two. I mean, this is great to hear. And it's great to hear, how your mission, how you deliver for the community and patients. I mean, it's no surprise you guys are quality leaders, and, the different outreach and different ideas you're doing. This is really helpful, I think, for everybody watching. Well, next up, this will move to our last question, and we'll start with you, Ken. And you actually said you like this question. So describe what the ideal health system in 10 to 15 years will be, and what capabilities it will have.
So that's easy, right? 10, 15 years, we know exactly what's going to be happening. So, what I feel strongly that the successful health system of the future will not be just a health delivery system, but it'll also be a data management system. And the ability to acquire and manipulate and apply data effectively towards care and outcomes is going to be crucial. I also believe that healthcare is going to stay abreast of developments in a lot of different areas. There's just no way that it isn't. And the successful health system of the future is going to be at the leading edge of the curve, for instance, in life sciences. So understanding disease processes better and coming up with new treatments or new diagnostics. The health system will be there. The successful health system will be at the leading edge of the curve in technology. The trends today suggest it's going to be virtual reality, augmented reality, artificial intelligence, machine learning, robotics. Something else will emerge. Healthcare will stay current with that. I think they'll be at the leading edge of the curve in financing and payment models, developing human capital, celebrating diversity, as I've said. That all said, at the center, there's going to be a person who has fallen ill, and it's going to be a healthcare professional that's holding their hand. I firmly believe, the patient-provider relationship has been foundational in healthcare forever, and it always will be. And it really helps us understand why we do what we do.
That's great.
That was,
you got to follow that.
I don't want to follow that, Ken. That's brilliant. And I actually feel the same way. The more that we try to digitalize everything, my reminder to everybody is that at the end of the day, that personal touch will never go away. It's hard to predict, 10 to 15 years out. We're already doing that as we build our new buildings. And I have no idea what how do I know whether I need the TV on this wall or that wall? We designed all of our rooms with that white care board, everybody had to write on. Guess what? Those are outdated already, because now everybody wants it electronic. So for me on the digital side, it's a little difficult to say what it's going to look like. But some of what Ken said is actually what I have been thinking about, is the personalized care, right? As we get more involved with genetic testing and the precision medicine, like which drug is going to work for you. We're doing some of that, but we're not there yet, right? Because we still do a one size fits all. Here's remdesivir for COVID. And if you meet these criteria, you get it. Well, what if it doesn't work for me, right? And so a little bit more of that precision medicine is where I see things going. I do think there'll be much more home care. We're already seeing a lot of the surgeries that used to be done in-house being done now on the ambulatory surgical site. We'll have many more virtual ICUs with people wanting to stay home more, which goes back to the regionalization idea. I can have one ICU doc, with a screen of people versus having to have one at every single site. You still need the on-site people, but I think the support that we can give, across the country is going to be there for sure. There's already reports of virtual ICUs, in-house. I kind of think of that as being really a centralized command center where you don't even have to be in the hospital. And so we're actually researching a lot of that as we speak. It's on our list of things to do in the next few weeks, is to try and develop a virtual ICU in addition to telestroke and the virtual psych and all the things that we're doing. But I do think the medicine will be much, much better and more accurate for each of our patients, individualized care. Ken, you have anything to add to that?
No, it's well said. The concept of N equals 1, right? Like, how do we reach each individual and tailor? I think that's really well said.
Well, this has been great. I mean, that concludes our panel.
Oh, so fast. I was thinking this is, I'm actually really enjoying this time together.
I know. Well, we could stay on after, but but thank you both again for joining. With our topic, physician executives and regional growth. So regional growth, whether organic or inorganic, is imperative for health systems as you continue to face increasing competition and other industry headwinds, some of the ones we noted today, including reimbursement pressures. So this has been a great discussion, and your experience and backgrounds, they truly have offered valuable insights on each of your organizations, as well as your perspectives on regional growth. So thank you both, and have a great one. Have a great day.
Thanks for having us.
Pleasure. Thank you.